Good evening, respected seniors, dear colleagues and friends. I'm really glad to welcome you all for another session, another academic session of IMA AMS Chapter Trivandrum. The practice changing updates. Today we are dealing with a very useful, very informative, very interesting session, Rabies, Facts and Prevention. Anyway, I'm not wasting much time. It's going to be very useful for every practitioner. First of all, I welcome Dr. S Vijayakrishnan, the respected president of IMA Trivandrum branch, to this session. He supports all our IMA AMS activities in a fantastic way. Dr. Althaf, Secretary of IMA Trivandrum branch, is expected to join anytime. He's participating in a media session on COVID. And Dr. Anand Marthandapillai, the convener of our chapter, is a very famous interventional cardiologist, young Turk. We work as a great team. I know I don't have to welcome him. We work as a great team. The faculty is my friend, Dr. Praveen KS. He's a consultant pediatrician for Taluk Hospital, Trivandrum. He graduated from TD Medical College, Alappuzha, and PG from SIT Hospital, Trivandrum. I am a fan of him. He's a simpleton, a silent, sincere worker, a great organizer, a very good academician, and a sincere friend. As a nodal officer of the COVID control cell Trivandrum during the peak of the pandemic, he did a fantastic job, working overtime, running around, organizing everything. I tell you, he's workaholic. And as a secretary of IAP Trivandrum branch, he did a very good job, and he got state level and national level recognition. He's currently the web editor of IAP Kerala. Welcome you, dear Praveen, to this academic session. And before starting the academic session, I request the President, Dr. S Vijayakrishnan, to say a few words. Over to you.
Thank you, sir. Respected AMS Chairman, Dr. Pradeep Kidangoor, sir. Convener, Dr. Anand Marthandapillai. നമ്മുടെ ഇന്നത്തെ സെഷൻ കൈകാര്യം ചെയ്യുന്ന ഡോക്ടർ പ്രവീൺ KS, respected seniors and dear friends. Indian Medical Association Trivandrum branch ഈ വർഷം നമ്മുടെ ഏറ്റവും വലിയ സയന്റിഫിക് പില്ലേഴ്സ് ആയിട്ടുള്ള AMS-ഉം CGP-യും വളരെ ആക്റ്റീവായിട്ട് തന്നെ സയന്റിഫിക് സെഷൻസ് കൈകാര്യം ചെയ്ത് മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുകയാണ്. കഴിഞ്ഞ 2 മാസത്തിനിടയ്ക്ക് വെച്ച് തന്നെ 10ഓളം പ്രോഗ്രാംസ്, ഡിഫറെന്റ് രീതിയിലുള്ള പ്രോഗ്രാംസ് നടത്താൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. അതിൽ ഏറ്റവും കൂടുതൽ പ്രോഗ്രാം നടന്നത് AMS-ന്റെ ബാനറിൽ തന്നെയാണ്. നമ്മൾ അടുത്ത വർഷത്തേക്ക് 2023 വളരെ ഫ്രൂട്ട്ഫുൾ ആയിട്ട് തന്നെ നമ്മുടെ എല്ലാവിധ പ്രൊഫഷണൽ എക്സലൻസും മുമ്പോട്ട് കൊണ്ടുവരത്തക്ക രീതിയിൽ ജേർണൽ ക്ലബും ക്ലിനിക്കൽ ക്ലബും മുതലുള്ള പ്രാക്ടീസ് ചേഞ്ചിങ് അപ്ഡേറ്റ്സും റെഗുലർ CME പ്രോഗ്രാംസും ഒക്കെ ആയിട്ട് തന്നെ ഒരുപാട് കാര്യങ്ങൾ പ്ലാൻ ചെയ്ത് മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നു. ഇനിയും പലതും AMS ചാപ്റ്ററിൽ നമുക്ക് പ്രതീക്ഷിക്കാവുന്നേ ഉള്ളൂ. കുറച്ചും കൂടി വിശാല അടിസ്ഥാനത്തിൽ അടുത്ത വർഷം നമ്മൾ കുറച്ചുകൂടി നല്ല രീതിയിൽ കൂടുതൽ പാർട്ടിസിപ്പേഷനോടുകൂടി ചെയ്യാനുള്ള പ്രോഗ്രാം നമ്മളിവിടെ പ്ലാൻ ചെയ്ത് വെച്ചുകൊണ്ടിരിക്കുകയാണ്. ഏതായാലും ശരി, ഈ പ്രോഗ്രാം നല്ലത് നടക്കട്ടെ. സംസാരത്തിൽ വലിയ കാര്യമില്ല, സയന്റിഫിക് സെക്ഷനാണ്. അപ്പൊ ആ രീതിയിൽ നല്ലൊരു സയന്റിഫിക് സെഷൻ നമുക്ക് ഇവിടെ പ്രതീക്ഷിക്കുകയും ചെയ്യാം. ഡോക്ടർ പ്രവീൺ KS നമ്മുടെ IMA ട്രിവാൻഡ്രത്തിന്റെ വെബ് എഡിറ്റർ കൂടിയാണ്. വെബ് എഡിറ്റർ എന്ന രീതിയിൽ മാത്രമല്ല, അക്കാഡമിഷ്യൻ എന്ന രീതിയിലും ഒരു നല്ല ഒരു ഓർഗനൈസർ എന്ന രീതിയിലും വളരെ കഴിവ് തെളിച്ച ഡോക്ടർ പ്രവീൺ KS നമ്മുടെ പല മാധ്യമ ചർച്ചകളിലും പങ്കെടുത്തിട്ടുള്ളത് തന്നെ ഡോക്ടർ പ്രവീൺ KS റൈബീസുമായിട്ട് ബന്ധപ്പെട്ട വിഷയങ്ങൾ ഉൾപ്പെടെയുള്ള കാര്യങ്ങൾ പങ്കെടുത്തിട്ടുണ്ട്. നല്ലൊരു അക്കാഡമിക് സെഷൻ ഞാൻ ഉണ്ടാകുമെന്ന് പ്രതീക്ഷിക്കുകയാണ്. എന്തായാലും ശരി, ഡോക്ടർ പ്രദീപ് കിടങ്ങൂർ സാറിനും ഡോക്ടർ ആനന്ദ് മാർത്തോളിക്ക് പ്രത്യേകം നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് പ്രോഗ്രാം നല്ല നടക്കട്ടെ എന്ന് ആശംസയോട് നിർത്തുന്നു. താങ്ക് യു വെരി മച്ച്.
So I welcome Dr. Praveen to start the academic session.
Thank you, sir. Good evening. Thanks for the nice words. First of all, I thank the organizers especially Dr. Vijayakrishnan sir, President, Dr. Althaf, Secretary, and my dear senior and friend, Dr. Pradeep Kidangoor sir, for giving me this opportunity. We can directly go to the topic. So, coming to rabies, rabies, the lethal untreatable disease, is always in the news headlines. And a few days back, we have seen in the news that Government of India have asked the states to make rabies a notifiable disease. So, as we know, India is endemic for rabies, and unfortunately, more than 1/3 of world's human rabies death transmitted by dogs happens in India, which is the highest in the world. It comes to around 20,000 deaths in India per year, which translates to one rabies death in every 30 minutes in India, which is the highest in the world. So rabies is a 100% fatal disease, but nearly 100% preventable. I have specifically used the term nearly because now we know that even after giving the correct post-exposure prophylaxis, very rarely patients can develop rabies. Among the total rabies death, around 40% are in the pediatric age group for multiple reasons, because they are due to their short stature, they are bitten in the face, scalp, upper part of the body, which are highly innervated areas, and the children are more likely to provoke the animals, and importantly, they might not report a bite or scratch. This may delay the post-exposure prophylaxis or treatment of the case. So coming to the animals transmitting rabies, we know that 99% of rabies occurring in human is transmitted by dogs, from the bite or scratch of dogs, followed by rats. But in fact, rabies is a viral disease which can affect all the mammals. So any mammal can get infected and transmit rabies. Next, we must know which are animals do not transmit rabies. Or in other words, bite from which all species does not need a rabies post-exposure prophylaxis. So in the vertebrate animal species, rabies is not reported in fishes, amphibians, reptiles, and birds. So any exposure to these animals or injury from these animals, fishes, amphibians, or reptiles includes our snakes, lizards, crocodiles, and also birds, does not require a rabies post-exposure prophylaxis. So there is a wide geographic variation in the animal reservoir of rabies. So we must know the animals that can transmit rabies in India, in our country. So apart from the domestic dogs and cats, we can get rabies from wild animals like foxes, monkeys, mongoose, then peri-domestic animals, cows, sheep, buffaloes, goats, donkeys, horses, camels, and the small mammals can also transmit rabies like bandicoots. Bandicoots are our large rats, nammude perichali. Then also squirrels are also can be carriers of the rabies virus. So a bite or scratch from any of these animals require a rabies post-exposure prophylaxis. So what about bats? We know that bat-mediated rabies is common in other parts of the world, like the US and the Latin American countries. In fact, bat-mediated rabies is the leading cause of rabies death in the United States. But in India, we don't have any case of reported bat-mediated rabies. Yet, bat being a mammal and also a carrier of rabies in other parts of the world, the recommendation is if we get a bite from a bat in any unusual circumstances, like from a forest area, it is always recommended for a post-exposure prophylaxis. So human-to-human transmission of rabies virus, as we know, is extremely rare, and the only documented cases of human-to-human transmission occurs via tissue or organ transplant. We have cases of organ transplant-mediated rabies, especially the corneal transplant. But however, the persons who are caring for the rabies confirmed cases, who are closely exposed to the secretions of a patient with rabies, should be offered a post-exposure prophylaxis as a precautionary measure. So now moving on to the pathogenesis of rabies, we know that once the virus enters our body, it's deposited in the muscles and connective tissue. There the virus replicates for at least for a few weeks at the site of deposition. Then being a neurotropic virus, if the virus is able to bind to a nerve ending, it suddenly binds to the nearest nerve ending, and actually it binds to the nicotinic acetylcholine receptors at the neuromuscular junction, and from there it travels in the exoplasm or the nerve towards the brain at a speed of around 3 millimeters per hour. which is around 7 centimeters per day. So there will be a rapid spread to the brain. So here we need to understand few points. One is the virus, once deposited in the muscles or connective tissue, can remain there for a very long time. The point is, however late the patient presents after an exposure of a dog or a cat, the patient should be offered a rabies post-exposure prophylaxis. Secondly, once the virus binds to the nerve ending or the motor end plate, none of our post-exposure measures works. So all the important post-exposure measures should be done before the virus binds to the nerve ending. Once the virus travels in the exoplasm, the patient develops the prodromal symptoms of rabies, and within few days, the rabies encephalitis will set in. So coming to the incubation period, this is mainly related to the distance the virus takes to travel to reach the brain. So it is normally around 3 to 8 weeks, but as I said, it can be as short as 4 days or maybe prolonged for many years. And it depends on multiple factors like severity of bite, number of wounds, the amount of virus injected, and importantly, the proximity of the viral entry to the central nervous system, and also the density of motor end plates at the wound site. So incubation period varies very much in case of rabies. In cases where the density of motor end plates or the bites in areas where the motor end plates are high, the risk of developing rabies is also high. So that's why the bites in face, fingernails, etc. are more dangerous. In humans, we have two forms of rabies are distinguished. One is the most common type, the encephalitic form or the furious rabies, which occurs in around 80% of cases. And the second, the paralytic form of rabies, which occurs in around 20 to 25% of cases. So coming to the clinical presentation of rabies, as we have already discussed, once the virus enters the nerve and it travels in the exoplasm towards the brain, the patient will start developing the prodromal symptoms. The first clinical symptoms will be non-specific. It will be fever, malaise, headache, and paresthesia or sensory changes at the site of bite may be present. That may be the initial presenting symptom. Then once the virus reaches the brain, the patient develops the symptoms of rabies encephalitis. The patient gets the classical features of delirium, abnormal behavior, hallucinations, and the typical hydrophobia, aerophobia, insomnia, etc. In this, the characteristic finding symptom we know is the spasm of the pharyngeal muscles triggered by an attempt to drink water, that is hydrophobia, or by blowing air on the patient's face, that is the aerophobia. So once the rabies encephalitis symptoms develops, usually coma and death usually happens in 2 to 6 days. But this is a classic clinical presentation. But apart from that, in a rabies endemic country like ours, rabies should be included in the differential diagnosis of any case of acute rapidly progressing encephalitis, even if the patient does not recall any history of an animal bite. So next is regarding the laboratory diagnosis methods of rabies. As with any other virus, we have different modalities of diagnosis of rabies is currently available, in which the detection of rabies viral antigens by FAT or fluorescent antibody test is the most commonly used test for the diagnosis of rabies, and WHO also recommends FAT or fluorescent antibody test for the detection of viral antigens as the most important test for diagnosis of rabies. But now we have other methods like detection of viral nucleic acid by PCR, and also detection of virus antibodies in the serum or CSF of an unvaccinated person can also be taken as a diagnosis, because vaccinated persons will have neutralizing antibodies in the serum. So these methods are most commonly used for the diagnosis of rabies. And we know in our state, previously our PALOD, State Institute of Animal Disease, and the Manuti Veterinary College were the only place where the rabies diagnostic tests were done. They were doing this FAT fluorescent antibody test for many years, and now we have our state public health lab also started doing FAT fluorescent antibody test and PCR for the diagnosis of rabies. So anyone coming across any case of suspicious rabies can send sample to our state public health lab for PCR as well as FAT after informing them. So what are the samples to be taken for diagnosis of rabies? In case of antemortem diagnosis, that is when the patient is alive, we can take samples like conjunctival smear, saliva, CSF, TS, skin biopsy, including the hair follicles from the nape of neck. These can be sent. But among this, the samples with the highest diagnostic sensitivity is said to be 3 saliva samples taken at the interval of 3 to 6 hours, along with skin biopsy, including the hair follicles. So this is the sample with the highest diagnostic sensitivity, antemortem. So why 3 saliva samples are taken? It is because due to the intermittent shedding of the virus in the animal's saliva, so in the patient saliva. So ideally, the samples taken should be stored at -20 degrees Celsius. But if you are transporting to the lab immediately, it can be transported in a cold chain in a viral transport media at 2 to 8 degrees Celsius. If you are getting a positive result in an antemortem sample, it's diagnostic of rabies. But the problem is, with a negative result, we cannot rule out rabies. One more thing about the nuchal skin biopsy. As I have already told, skin biopsy along with 3 saliva samples are having the highest diagnostic sensitivity. When we are taking a skin biopsy, the specimen ideally should contain minimum of 10 hair follicles and should be a sufficient depth to include the cutaneous nerves. So this is regarding the antemortem diagnosis samples of rabies, and the postmortem diagnosis in both animals and humans, the brain tissue is being used. So coming to the important part of our talk, that is the post-exposure prophylaxis. As we know, it's a 3-pronged approach. First is the local treatment of the wound. Second is the rabies vaccination. And third is the rabies immunoglobulin. And all the 3 approaches are equally important, and this should be done as early as possible after an exposure, because once, as we have already discussed, once the virus binds to the nerve ending, none of these post-exposure prophylaxis works. So the aim of the post-exposure prophylaxis is to mechanically remove or neutralize the inoculated virus before it enters the central nervous system. So this is a graph which compares the viral multiplication, the antibody response following vaccination, and the role of immunoglobulin. Here the viral load or viral multiplication is shown in a red line. The antibody response following vaccination is shown in the blue line, as well as the immunoglobulin or the rabies immunoglobulin is shown as the green line. As with any other vaccine, the antibody response following rabies vaccination will take time. Even if we are giving the vaccine in a short course, like 037, the antibody will take at least 7 to 14 days to rise to the sufficient level. So in the initial period, when the virus multiplication is in there, the protection is by the immunoglobulin or the rabies immunoglobulin. That is the importance of rabies immunoglobulin, that will cover for at least 1 to 2 weeks till the vaccine mediated antibodies will take over. So coming to the classification of animal bites, which we all are very famous. The category 1, that is the touching or feeding of animals with licks on intact skin. There is no exposure here, and no treatment is required if the history is reliable. And the category 2, that is nibbling of uncovered skin and minor scratches or abrasion without bleeding. This is taken as a minor exposure. Here, local wound treatment along with anti-rabies vaccine is needed. And category 3, single or multiple transdermal bites, licks on broken skin, contamination of mucous membrane with saliva, and bite by wild animals. So what we must understand here is this categorization, what is taken, the parameter here taken here is the depth of the wound. Not the length or size or site of the wound is taken into consideration while categorizing or making this risk assessment. So regarding category 1, there is no exposure. The difference between category 2 and 3 we must understand, because in category 2 there is no break in the integrity of the skin. That is because it is above the dermis. So the chance of the virus entering the skin and binding to a nerve is actually very less. So the chance is actually remote. So even if the patient virus enters and attaches to a nerve, it will take time. That's why the vaccine will get enough time to make sufficient antibodies. That's why in category 2, we are giving only anti-rabies vaccine. But coming to category 3, there is a break in the integrity of the skin. The saliva of the virus will enter into the dermis, and the chance of the virus finding or entering into the nerve ending is very high. So even if 1 drop of blood is seen from a single wound, it should be taken as category 3. One method we can use is if we are in doubt, even if it is not approved by the government, we can use a spirit swab. We can apply a spirit swab to the area. If there is a stinging sensation, we can take it as a category 3. So in category 3, around more than 90% of cases reporting to our hospital or healthcare institutions are category 3. So we must actually take every wound as category 3 unless otherwise proven. Then exposure to wild animals should also be taken as category 3, even if the original categorization is category 2. And whenever in doubt, the post-exposure prophylaxis, that is the post-rabies PEP, it is always prudent to over-treat than under-treat. That's because being a disease with 100% mortality, if we are in doubt, it is always better to over-treat. So what about the PEP for an immunocompromised individual? In immunocompromised individual, recommendation is that all the category 2 wounds will be taken as category 3 and the immunoglobulin will be given. And the route of vaccination is always IM route in immunocompromised individuals. And the facilities are available, and anti-rabies antibody titer estimation is recommended for immunocompromised individuals after 14 days after completion of the vaccination. So another doubt everyone will have is what if a vaccinated pet bites you? Most of our dogs may be vaccinated, we know that the mass dog vaccination is one of the important tool in rabies elimination. So in an ideal situation, if the dog is properly vaccinated and the efficacy of the vaccine is confirmed by a lab test, we can avoid the post-exposure prophylaxis. But the problem is the vaccine efficacy in animals varies widely. Most of the manufacturers claims is to be up to 90%. So practically we see the efficacy of animal vaccination to be 60 to 70% only. And also animal vaccination failure may occur due to multiple reasons like improper administration, inadequate dosage, poor quality of vaccine or health status of the animal. So for all practical purposes, irrespective of the vaccination status of the biting animal, post-exposure prophylaxis should be given. So what about observation of the biting animal? Sometimes we may ask whether we can wait for 10 days and start the post-exposure prophylaxis. Nothing like that. PEP should be started immediately after the exposure. And the only thing is if the dog or cat is healthy after 10 days, and we are using an IM regimen, we can skip the day 14 dose and convert it into the pre-exposure prophylaxis. That is the only thing if the animal is healthy after 10 days. If we are using an intradermal route of vaccination, there is no dose on day 14. And so there is no change in the schedule of vaccination, even if the animal is healthy after 10 days. So the one more thing regarding the observation is this observation period of 10 days is valid only for dogs and cats. So that is because the natural history of rabies in other mammals are not fully understood, and therefore the 10-day observation period is only valid for dogs and cat. So coming to the important first step in the post-exposure prophylaxis, that is the wound management. The aim is to remove maximum possible saliva or virus from the wound. According to many studies, up to 80% of the virus can be removed if we do a proper wound management or wound care. So this is a very simple, effective measure, but very often forgotten by both the patient as well as the caregivers. Here, the recommendation is to do a proper washing in running water and soap for 15 minutes. This will aid the mechanical removal of the virus. The soap will inactivate the virus, followed by a chemical inactivation with any of the virucidal agents available. Can use povidone, iodine, alcohol, etc. So this is a very effective step in removing 80 to 80% of the virus. So this brings us to a very important question. Does our hospitals or healthcare facilities have a proper wound washing facility? So because most of the time when a person gets a bite or a scratch from a dog or an animal, they will rush to the hospital for the vaccination. So when reaching the hospital, even if the doctor advises them for a proper wound washing, there won't be any facility at the hospital for wound washing. So it is strongly recommended that in every healthcare facility which provides a post-exposure prophylaxis like vaccination or immunoglobulin should have a wound washing facility. Next is regarding the management of the animal bite wounds. The dictum in any animal bite is that the wound should not be sutured at once. The reason is when we are suturing, this can cause additional trauma which can inoculate the virus deeper into the wound. So this may help the virus to attach to a nerve ending. So severe bite wounds are best treated by daily dressing followed by a secondary suturing when necessary after infiltration of rabies immunoglobulin. This can be done 24 to 48 hours later after giving the rabies immunoglobulin. In some cases, the wound may be very large, multiple wounds. This may need a immediate suturing. In that cases, we can do a minimal suturing after infiltration of RIG, and we should give at least few hours to allow the diffusion of rabies immunoglobulin through the tissues. And if a person usually comes with an animal bite, our focus will be mainly on the rabies vaccine and immunoglobulin. We may forget the tetanus toxoid as well as the other modalities in the wound management. So injection TT should be given if required, and antibiotics should be given depending on the severity of the wound. So coming to the vaccines, rabies vaccines, most of the vaccines now available in our country are modern cell culture vaccines. Previously, we were using the nervous tissue vaccine that is not being used now. Human diploid cell vaccine was being used. Our Serum Institute was producing one HDCV or human diploid cell vaccine. This was also now stopped. Now, most of the vaccines available in our country are modern cell culture vaccine. For all practical purposes, there are no difference in the efficacy or safety of these vaccines, no difference in protection size titers. So this can be, any of these vaccines can be used, and if needed can be interchanged also. There is one new subunit vaccine we will see in the next slide, and being developed in our country now. Then the site of vaccination is very important in rabies. The deltoid region is the ideal site for administration of vaccine, and gluteal region is not recommended because of the fat present in this region may retard the absorption of vaccine. This is a new 3-dose subunit vaccine developed by Cadila Pharma, which got the drug controller approval, but this is not currently into our guidelines because this is a new vaccine and it's a 3-dose vaccine. Just for your information, their tagline is 1, 2, 3 rabies free. This is called Rabies, and we don't have enough data. And once we get enough data, it may get incorporated into our guideline. So coming to the 2 regimes of anti-rabies vaccines, which we are very famous, the intramuscular regime, the SN regime, or the intradermal regime, or the updated Thai Red Cross regime. The immune responses induced by both the regimes are comparable, and in fact, in some studies, the intradermal regimes seems to have better immunogenicity. But recently, the efficacy of the intradermal regime is being questioned by even from our doctor's side also. But we must understand that the intradermal regime was initially recommended by WHO way back in 1992. So we have now enough data that the intradermal regime, if given properly, is as good as the intramuscular regime. So this is the intramuscular regime, 5 doses, 5 visits on 0, 3, 7, 14, and 28. And the intradermal regime or the updated Thai Red Cross regime, here day 14 is not there, but every day there is 2.1 ml intradermal prick. So 8 doses and 4 visits. That's the intradermal regime, which is being currently used in our government setups. So the problem with the intradermal regime is the intradermal injection, as we know, it requires more skill than giving an IM or subcutaneous regime. If the vaccine is being injected too deeply to the skin, that is, it goes to the subcutaneous tissue, it won't be efficacious. So while giving an intradermal injection, there should be a blub formation. The raised blub of 3 to 4 millimeters should appear immediately after the vaccination. If the blub is not seen, the intradermal vaccine should be repeated at an adjacent site. This is very important, and we must teach our staff in giving intradermal injections, and it should be monitored by the doctors actually. And if the blub is not seen, the vaccine should be immediately repeated at an adjacent site. And the site for IDRV is also in the deltoid region. If the deltoid is cannot be given in the deltoid for some reasons, can be given in suprascapular or under anterolateral. type. Regarding the storage of vaccines, the reconstituted vaccines should be used as soon as possible or within 6 to 8 hours. If any unused vaccine is there, should be discarded after 6 to 8 hours. So when we prescribe a post-exposure prophylaxis vaccine schedule, the patient should ideally be informed clearly about the schedule, both verbally as well as in a written prescription. But many times we may see patients forgetting the schedule and coming on a different date. So the question here is, do we need to restart the schedule if a person misses a dose? Here, the problem is a slight difference in the guideline from the Government of India and the WHO guidelines. As per the WHO guidelines, the latest released in 2018, there is no need to restart the vaccine even if a person misses a dose. But at least for the legal point of view, we must follow the Government of India guideline. That is the latest, was published in 2019. The Government of India guideline says that the patient should complete 3 doses of the vaccine in a maximum of 10 days. That is, the first 3 days, 0, 3, 7 should be completed within 10 days. And 1 or 2 days of deviation do not necessitate restarting. But they clearly says that if a patient fails to visit on the scheduled date of first 3 doses and misses 1 or more dose, that is, the patient is not taking the first 3 doses in 10 days period, we may consider giving an additional dose. This is the Government of India recommendation. I personally feel we should practice the Government of India guideline, at least for the legal point of view. And switching of the route of administration from IM to ID, intradermal or vice versa, is not routinely recommended, but can be given in an unavoidable circumstance. So coming to the rabies immunoglobulin, we have mainly using the human and the equine rabies immunoglobulin. The dose is different. It is 20 international units per kilogram for human and 40 international units per kilogram for the equine rabies immunoglobulin. And previously there was an upper limit for both of them. Now there is no upper limit. We can use the maximum per kilogram dose. And this RIG is human RIG is derived from human volunteers immunized with the vaccine, and equine is derived from horses. The basic thing is we should not exceed these doses, because the dose is calculated such that the immunoglobulin should not suppress the vaccine response. So when the recommended dose is exceeded, it may suppress the immunogenicity of the vaccine. So we should not exceed the maximum recommended dose. If there are more wounds, we can dilute the immunoglobulin in normal saline. Problem with the equine RIG is always everyone is fearful about the side effect or the risk of anaphylaxis. But the problem, so whether we should do a skin test prior to giving this equine RIG is always a question. In 2019, both the Government of India as well as WHO says that the skin test prior to administering a equine RIG is not required, because the testing does not accurately predict adverse reaction. So even if the skin test is negative, the person may develop anaphylaxis. Just because the skin test mainly predict the reaction, the IG mediated reaction, but the severe anaphylactic reactions may be other complement mediated and other mechanisms may be active. So the skin test ideally cannot predict a reaction. But the problem is most of the manufacturers even now recommends a skin test prior giving the equine RIG. So we should do a skin sensitivity testing if it is recommended by the manufacturer and is written in the product information. But we must be aware that even if the skin test is negative, we should take all precautions for treating anaphylactic reactions. But the point is, the modern, recent equine rabies immunoglobulins are very purified products, and the risk of anaphylaxis is very, very rare. So if a patient is allergic to equine RIG, we can use human RIG. The human RIG does not require a prior sensitivity testing. And next is regarding the administration of rabies immunoglobulin. This is another important area in the post-exposure prophylaxis, where we need to train our staff. First, we must understand how to give it, and we must train our staff. Previously, we know that long back, all the IM, full dose of the calculated dose was given IM. Then it changed to 50% local Paediatrician and 50% IM. Now, as per the latest evidence or the latest Government of India recommendation, the entire immunoglobulin dose, the calculated dose, should be given into or around the wound. Should be as much anatomically possible. The maximum calculated dose should be infiltrated into and around the wound. And evidence suggests that the injecting the rabies immunoglobulin in a distant anatomical site does not provide any protection. So previously we were giving intramuscularly into a distant site. The rationale is in rabies there is actually no systemic viremia. So even if we give the immunoglobulin to a distant site, there it cannot neutralize the local virus. That is the issue. So the current recommendation is the maximum calculated dose should be infiltrated into the and around the wound. So if the calculated wound dose is not sufficient to infiltrate all the wounds, it is advisable to dilute immunoglobulin in normal sterile saline. So we can actually dilute up to 8 to 10 times if required. And if there is a mucosal exposure, the wound rinsing with RIG is also advisable. If the rabies immunoglobulin is not administered with the first dose of vaccine, it can be given up to 7th day. So if a patient comes and if the rabies immunoglobulin is not available, we can start later up to 7 days of starting the vaccine. So this is a video showing the method of administration of RIG. The needle should go from outside to inside the wound, and there should be a continuous movement, and all the area of the wound should be infiltrated till the immunoglobulin oozes out of the wound. We have the monoclonal antibodies, which are highly purified concentrated products, and 2 monoclonal antibodies are currently available in India. Basically these are cheaper than our human immunoglobulin. And the first one, that is the Rabishield or R-Mab, which is the world's first human monoclonal antibody against rabies, which binds to the ectodomain G glycoprotein of the rabies, which is recommended by WHO. No skin sensitivity test is required, and the dose is 3.33 international units per kilogram, and the approximate cost for a 60 kilogram person comes to around 3,800 rupees, whereas for a human rabies immunoglobulin it may go up to 20,000 rupees. The second antibody, monoclonal antibody against rabies currently available in India is the TwinRab, which is actually a which is actually a cocktail of 2 monoclonal antibodies, and the dose is 40 international units per kilogram body weight. It's little more costlier than our Rabishield. It comes to around 60,000 rupees for a 60 kilogram person. So what will we do if a person gets a re-exposure? A person who have taken complete pre-exposure or a post-exposure prophylaxis gets a re-exposure after a certain period of time. Here, in 100% of persons, the protective antibody titers have been documented to last at least 90 days. So the recommendation is, if a person who takes a complete pre or post-exposure prophylaxis gets a re-exposure, if it is within the last 3 months, only adequate wound washing is needed. And if it is after 3 months, only 2 doses of vaccine. If you are using an IM schedule, 2 doses on day 0 and 3. And if you are using an intradermal schedule, you can use a single site intradermal on day 0 and 3. But the message here is we should check for the document or a proof of a complete pre-exposure or post-exposure prophylaxis. Whether the patient can produce a proof for the vaccination, it is very important. So coming to the pre-exposure prophylaxis, ideally it is recommended strategy for persons with high occupational risk. But we know that in a rabies endemic country where there is no control of the stray dog population, and the people are very lax about annual rabies vaccination for their pets, it's actually a cost-effective strategy for taking this pre-exposure prophylaxis for every person, especially kids. And the recommended schedule is either IM or intradermal. IM is 3 doses, 0, 7, and either 21 or 28, and intradermal it is 0, 7, and 21 or 28 single site. In persons with a high risk, there is a recommendation for checking the antibody titer every 6 months for the initial 2 years, and after 2 years every 2 years after that. And antibody titer, if it is less than 0.5 international units per ml, a single booster dose is recommended. This is not for the ordinary people or doctors or medical professionals. This is for persons who are at high risk of getting rabies, like laboratory staff and persons at continuous risk of exposure. So coming to the most discussed and debated question, is there a possibility of failure of post-exposure prophylaxis? And yes, there can be a failure of post-exposure prophylaxis, and the most common causes are: one is the delay in seeking treatment, second is the improper wound care, third is the improper technique of vaccination, especially regarding the intradermal vaccination. The intradermal vaccine should go intradermal only, and if it is go subcutaneously or intramuscular, the failure rate is it will go to a failure. And regarding administration of RIG, the proper administration method should be followed. Then there can be some unnoticed minor wounds which are left, which are not infiltrated. If they are not infiltrated by rabies immunoglobulin, there can be a post-exposure failure. Then lack of patient compliance to vaccination schedule can be another cause. And last, we can say that the quality of vaccine, because previously in the last few months there was very much media discussion about the quality of vaccine, and post-exposure failure. Maybe the failure of vaccine, quality of vaccine as a reason for the failure of post-exposure prophylaxis, but this should be taken as the last chance only, because the rabies vaccine is not a very heat sensitive vaccine, and it is stable in room temperature for at least for a week. So the quality of vaccine causing a rabies post-exposure prophylaxis failure is very less. And finally, the failure of PEP, the most important cause or the reason which we cannot sometimes avoid, is the direct inoculation of the virus directly into the nerve. In this case only the rabies immunoglobulin will work. So now WHO as well as the government of India is in a mission to eliminate dog mediated rabies by 2030. It is called 0 by 30. Dog mediated human rabies free India by 2030. Now an action plan is there, and the two main strategies are mass dog vaccination as well as animal birth control. And one point I want to reiterate is the importance of pre-exposure prophylaxis, and as well as the capacity building of our staff regarding the intradermal infiltration as well as the rabies immunoglobulin administration. So to summarize, most cases reporting to our OPDs are category 3. And if in doubt, we can use a spirit swab. And when in doubt, it's always prudent to over-treat in case of a rabies post-exposure prophylaxis. And there is no role for IM administration of RIG. And pre-exposure prophylaxis should be given to all the persons, especially for the kids. And monoclonal antibodies are the future, being cost-effective, safe, and available in unlimited quantities. And awareness to the public is always very important in the prevention of rabies death. Thank you.
Dr. Anand Marthandapillai, I request Dr. Anand to start the discussion.
Thank you. Thank you, Dr. Praveen, for a very exhaustive coverage. Pretty much all that needs to be talked about. I'll be wondering if there are actually any doubts beyond what you have covered. We'll quickly go to the chat box where there are a couple of questions. I'll go through that. The first question is from Dr. George Jacob. I hope you can also see the chat questions. Question is, what is the longest period of incubation recorded?
Yeah. We have a documented cases of rabies incubation period up to 6 years. What I found in the literature is up to 6 years. And second question is regarding the eagle attacks, and that I have actually covered in the initial slides, because birds are not carriers of rabies virus, and they cannot transmit rabies. So a bite or attack by a bird doesn't need a post-exposure prophylaxis. Second is a rabbit bite. Rabbit being a mammal, there is a remote chance, and if it's better to give rabies post-exposure prophylaxis in a rabbit bite.
Dr. Praveen, there's another question. Is ARV indicated? Is that for eagle? Okay, that was for the
Yeah,
eagle.
yeah, that's for the bird.
Okay.
Can we advise rabies vaccination to all kids? Yes, yes, that should be the very important take-home message for from this. Actually, I think IMA or IAP can take the initiative for school-based pre-exposure prophylaxis for the children. It's better to take pre-exposure prophylaxis for all kids, because kids may sometimes hide the injuries. That's the one important thing we usually see. And also, if there are some unnoticed exposure also, if we are taking the pre-exposure, the child will get protected. Regarding the pre-exposure prophylaxis, how long the pre-exposure prophylaxis lasts? So as per the available data and the recommendation, the pre-exposure prophylaxis is lifelong. If you are taking a complete post-exposure or a pre-exposure complete prophylaxis, lifelong, you need only 2 doses. That is 0 and 3. That is the current recommendation. Is there any viremia in a bleeding wound? Why virus? Basically, this rabies virus is a neurotropic virus. It is not causing a viremia. The virus mainly uses the nerve ending to enter the nerve roots and will travels to the brain only.
Praveen, you were talking about vaccinated dogs and domestic dogs. So are you saying that irrespective of if it is domestic, whether it is vaccinated or not, you would still recommend prophylaxis for a category 3 wound?
Yeah, definitely. In any category 2 or 3, even if the dog or animal is vaccinated in an endemic country and we don't know the efficacy of dog vaccination, the recommendation is to give complete post-exposure prophylaxis depending on the category of the wound.
I think Padmanabhan sir has a few comments to make. Sir, please go ahead. You can unmute yourself and tell us what your thoughts are.
Post-exposure, one question is there any proper contraindications during pregnancy? No. Rabies being a completely fatal, 100% fatal disease, there is no contraindication for any of the post-exposure prophylaxis measures. The drinking of milk of rabbit cow, that's a good question, because rabies virus is not being secreted into the milk of a rabbit cow, or eating the meat or drinking of milk is actually not a risk for developing rabies. So it is not recommended to take a post-exposure prophylaxis in the recent updates. So Padmanabhan sir has requested to unmute him.
Yes, let me see, sir. In the meantime, Dr. Praveen can take the other question.
Yeah, if a person has taken post-exposure vaccination, all doses will provide lifelong prophylaxis. Yes, as per the current evidence and current recommendations, if a person takes a post or pre-exposure vaccination, all doses, it is lifelong. They need only 0 and 3 after 3 months.
Okay, can I come in now?
Yeah, sir.
Yes, sir, please.
Yeah, Dr. Praveen has often, has very good talk, excellent talk. I don't know, there are about 50 people listening to it. See, this is a very important topic because sometimes, even if you don't make a mistake, it's sometimes you can't be 100% in anything in medicine. And one of the main things, and I would like to tell people, is that there are 4 or 5 guidelines which are there. The National Guidelines 2019. That is what you should follow. The WHO guideline is that it does differ. It does differ in important points. I will tell you that. Then the Indian Academy of Pediatrics, it also differs. Normally, we follow the WHO guidelines for immunization verbatim, but in this, I think we should follow the national guidelines because otherwise you can be in medical legal issues. Now, regarding one thing which I have found many IMA members, many pediatricians going to discussions and they're talking about how did this happen? How did this happen? Vaccinated children. Please understand, WHO, the first studies in rabies studies has been extensively studied in Thailand. Way back in 2000, at that time, I am talking of 2005 and all, they have clearly written that even if all the things are fine, the vaccine has been tested, Everything has been given properly. There were 14 reported cases of failure in that research center, and out of which 9 was proved that it was. Therefore, please, when you go for distribution, says that the vaccine, there is a well-documented failure for that. And another thing you have to think about is a monoclonal antibody with the rabies which is available. I think it is only manufactured in India. Therefore, you will not find it in the IAP, American Academy of Pediatrics, or any other guideline. You won't find it. And remember, the American Academy only recommends human immunoglobulin and not the rabies immunoglobulin. Let's forget about it. Now, the monoclonal antibody is very, very effective. Now, some of the discussions, even in IAP, emanated, people said that it is not effective against all the strains available in the field. No, it has been proved to be effective. It has, even the WHO recommends it. Therefore, you are fully justified in giving rabies monoclonal antibody if you are given. And remember, I think Praveen stressed this, you give rabies immunoglobulin only once in your lifetime, only once. Monoclonal antibody is all right. And remember another thing, all wild animals, unknown bites, are category 3. Why I'm telling you this now, people have become taking a fancy for trekking. They go, they come back, they find a small scratch in the leg, whether something bit, something didn't bite, nobody knows. You have to give them category 3 bite. And another question, often I was working in General Hospital 1980, where we had a rabies ward there. That was the only place where rabies patients used to be put. The nurses would come and say, "Doctor, we would like to," they were not ready to go into the cell. Doctors were not prepared to go inside. Human to human transmission is almost unheard of. But I am stressing here, the national guideline says if the relatives are very concerned, give the dose. Therefore, doctors should know this. Everybody would say, don't give, don't give. Therefore, my recommendation to you, as much as you are listening to Dr. Praveen and others, and please get this guideline, national guideline, and read it. If you are dealing with rabies immunization, don't make any difference regarding it. Also understand, I said that there is a difference. See, the WHO in 2018 has not given 5 doses. And remember, I want to tell you one thing here. The Indian Academy of Pediatrics does not advise intradermal doses. They say in private practice, there is no place for intradermal doses. Why are you giving for immunosuppressed patients only IM? That means IM is superior. That is their way of argument. But I'm just informing you, if you are a private practitioner pediatrician, the Indian Academy of Pediatrics does not. I will place it only number 3 in the category in which I would listen, because first would be the national guidelines, because we have to protect ourselves than anybody else, anything else. Now, let me therefore, regarding this, what you call bats, the national guideline says no. Therefore, you are fully justified in saying no. But remember, the bat bite may just be a small pinprick. And that is what, therefore, it is something you will have to think of twice before you say no. But you are legally protected if you don't give, because the national guideline says no. And not by fomites. You know, you touch something, the saliva of the patient is somewhere, you touch something in the. Now, the most important thing which Praveen said, but I would like to stress on you, I had a problem here, pet animals. Now, the IAP has copied and pasted what the American Academy of Pediatrics has said. And they have said that if you have a pet animal, which is given the first dose after 3 months and the second dose after at the age of 1 year, if the animal is about 1 year and it scratches, you can wait. You can observe the dog. You need not give vaccination. This is the American Academy of Pediatrics recommendation followed all over the world. They say for rabbit, cat, and dog bites. They advise this in the Western. But, again, a very important but, which Praveen has stressed also, national guidelines. See, they say even if your pet is immunized, you have to give because it is not very effective. Read between the lines. The government which is producing this vaccine is telling that the vaccine is not 100% effective. Therefore, don't make the mistake. Because I have had a tough time with a veterinary surgeon who was angry with me because he had fully immunized the child and I was telling the patient, you better get immunized. Therefore, remember, this is a national guidelines and you have to follow it. And if you're washing with soap for 20 minutes, it's good. But if you are putting Dettol or something after that, remember the soap has to be completely washed off with water or the soap will. Therefore, these and any unimmunized bird drop. Now, another final thing, and nobody interfered in my talk. I don't know whether you're getting it better. I mean, the last thing you remember is Praveen stressed 90% of the bites are category 3. I've seen so many times people coming and said, no blood, no blood. But then when you ask, bit over your dress, how was it? That means it's a bleeding. And regarding the spirit, I didn't know about it. So these are the points which I want to say. If I had taken too much of your time, I am sorry. Thank you.
Thank you, sir, for the very valid points.
I recommend everybody follow the national guidelines. I don't want anybody to be in trouble because here you are judged by a mistake, not by what you do correctly. If you are supposed to make a mistake, you had it. That's it.
Dr. Praveen, I think there are a few more questions. Casualty should be used new vials after 8 hours of
Yes, definitely. Even if you are keeping it in a 2 to 8 degrees Celsius, one vaccine vial open should be used for only for 6 to 8 hours, and after that we should be taking a new vial. That's the recommendation.
Monoclonal antibodies, that is also locally injected, or how is that administered?
Yeah, monoclonal antibody, the route of administration and the method is same as that of the rabies immunoglobulin. And only thing is that, as Padmanabhan sir said, the national guidelines that is published in 2019 actually officially doesn't recommend a monoclonal antibody. They still wants us to use the equine or human RIG. Even if the monoclonal antibodies are widely available in the market and is approved by the drug controller, it is not part of the national guidelines. So at least in the government settings, we are not legally safe in using the monoclonal antibody. One point that Padmanabhan sir has told us that regarding the efficacy of monoclonal antibody, and that is regarding the R-Mab or our Rabishield from Serum Institute. And one problem that is said is we cannot neutralize one variant of bat virus, that is a Peruvian bat virus, which is not present in India. So ideally, as per WHO recommendation, it can be used, but the national guidelines differs. That's the issue.
But Dr. Praveen, am I here? Can I hear you?
Yes, sir.
See, I went through the national guidelines very carefully. It doesn't say anything about monoclonal antibody. See, this is usually the problem when the cost is high. They don't want to say about something. The cost of the monoclonal antibody comes somewhere in between the immunoglobulin which you give, that is equine immunoglobulin, and the human immunoglobulin. This comes in between them. Therefore, the national guidelines does not say you should not give or you should give. It doesn't mention anything, doesn't discuss it. And as far as I know, but the WHO and the Indian Academy of Pediatrics, ACUFP, definitely says that it is. The funny thing is, the WHO in its slide itself says that human monoclonal antibody is recommended and it may be more effective. That's the sentence they use. But I think you are legally protected in giving it, because the national guidelines doesn't say don't give. They just keep quiet on that. Understandably, you understand, because they cannot afford it in the government sector.
Sir was also saying that immunoglobulin can only be given once in a lifetime.
Yeah, that's all that is required. But remember, when you have given already a PEP, pre-exposure prophylaxis, the second time you get bitten, there's only 2 doses. But if you become over anxious and give an immunoglobulin, then you have to give the full dose. Because that is a thing about it. Therefore, this is given is once you have given immunoglobulin, it is not repeated. That's what I mean. Praveen can talk about it. That's what I have seen being discussed as well as I have read.
Yeah,
Right.
that's the point. Once the person has taken a full pre or post exposure prophylaxis, that person only needs 2 doses of vaccine and not immunoglobulin in case of a re-exposure. That's because when a person is fully vaccinated, that at least that the person take at least 3 doses of rabies vaccine. When the person gets a re-exposure and take 0 and 3 dose of booster, the immune response will be very rapid. When the person takes apart from that, when the person takes the vaccine for the first time, the immune response will be slow. That we have discussed in the talk that it will take at least 7 to 14 days. That is the reason why in the first exposure we are giving immunoglobulin also. But during a re-exposure in an already vaccinated person, the vaccine will take very short time for building up a good immune response or the antibody response. So immunoglobulin is not at all required in that case.
Now, another thing which we can make a mistake is that sometimes patient will come after 6 months or 8 months. You have to give the immunization. You have stressed it. But they say you have to give the immunoglobulin also, because the patient will normally come with some symptoms developing, and then the immunoglobulin can be given after the first dose of vaccine within 7 days. But you have never vaccinated the patient comes after 7 months, and you are starting the vaccine, you can also give the immunoglobulin, provided the wound site is there. These can be very tricky issues. You may not give, you may think 7 days has passed. That is between the first dose you are given vaccine in 7 days. I suppose I'm clear.
For clinical encephalitis, apart from supportive care, is there any other treatment? Is there a role for monoclonal antibody in clinical treatment?
Nothing. I don't think anything happens.
I think there is no role for any monoclonal antibody in the clinical treatment of rabies. Only supportive treatment is offered.
There have been few survivors who have been ventilated for 1 year, 2 years, but all of them have been completely vegetable state. Nobody comes back to normalcy with the full-blown rabies.
We have 10 minutes past 9 o'clock. If there are no other questions from the audience, I think we can conclude. It was extremely educating and exhaustively covered topic. Special thanks to Dr. Praveen. Also thanks to our IMA President Vijayakrishnan sir, AMS Chairperson Pradeep sir, and special thanks to Padmanabhan sir for joining us today, as well as for his editorial comments and a lot of insights and practical tips as far as managing dog bites are concerned. If there are no other questions or discussion points, I think we'll conclude. Thank you all.
Thank you.
Thank you once again.
Thank you, Dr. Praveen.
Thank you, sir. Thank you, Pradeep sir, as well as
Thank you.
Anand. Thank you.
Thank you, Praveen. It was excellent.
Thank you. Bye. Good night.
Thank you, Padmanabhan sir.
Thank you.
Sir.